Thank you. So, um, thanks everyone for having me. My talk today is about engaging community to increase diversity in clinical trials, and I'll just be sharing with you a little bit about what we're working on in the Office of Healthcare Equity. And I started out with this this sort of speech, or not a slogan, but it's called "Nothing About Us Without Us." And I heard this in one of our KPMP community meetings, and I thought that that is something that we need to keep in mind with our community. That that was first invoked. This statement was first invoked by the South African disability rights movement in the 1990s, and they've now just changed it to "Nothing About Us," nothing without us, instead of "Nothing About Us Without Us." So I sort of keep that in the back of my mind when I'm thinking about research and thinking about equity issues, that we really need to increase our involvement of our community, especially in the research that we do. So I'm also going to start with honoring of the land on which the UW stands. And so the UW acknowledges the Coast Salish people of this land, and it's the land that touches all the shared waters of all of our tribes and bands within the Suquamish, Tulalip, and Muckleshoot nations. And here in the Office of Healthcare Equity, we also acknowledge the Duwamish tribe and all the indigenous folks of this land. So go a little bit about the background of health inequities. We know that they're pervasive and that they contribute to increased morbidity and mortality among individuals from marginalized communities. Our Black, Indigenous, and other communities of color, Latinx, LGBTQIA+, and other marginalized populations, as well as rural and low resource populations, and I would say abled and disabled populations, are also disproportionately affected. There are high inequities. Our healthcare inequities are very, very costly, and they account for an estimated $4.51 billion in cost. And research utilizing collaboration with minoritized populations is at the center of a new framework that we hope to use as we move forward with this new diversity in clinical trials that I'll talk about. So this is a paper from Labiste that was published in 2023 that tried to actually characterize the burden of racial and ethnic minority groups and the cost of the economic components of this burden. So Black and African Americans have about a $310 billion cost for healthcare that is burdened by this group. For the Hispanic, Latino, Latinx population, it's about 94 billion. American Indian and Alaska Native, 26 billion, and Native Hawaiian, Pacific Islander, 12 billion, and Asian, about 8 billion. And a lot of the excess costs is due to excess or premature deaths in some of the populations. So that's just an idea of where those costs are. We know that in clinical trials in particular, and just healthcare trials, there's this prior history of atrocities that have occurred, and I think that there are we know that there's a lot of mistrust, especially in the Black and Indigenous populations in this country, because of what has happened. And this is just to remind us that there's a lack of equity and patient autonomy. And I'll start with Anarcha, Betsy, and Lucy, who were enslaved Black women who were operated on by Mario Sims, who is called the father of OBGYN, of obstetrics, who were operated on without anesthesia. He developed a lot of the speculum that we still use, and did it on these enslaved Black women. Henrietta Lacks, and this is a picture of her and the development of the HeLa cell. So Henrietta Lacks was admitted to segregated Johns Hopkins, where she had terminal cervical cancer. Her cells from her cervix were taken, and that's where the HeLa cell was developed. And for those of you who don't know, the HeLa cell became basically the cornerstone of research and cellular research. And so we owe a lot to this woman, where her cells were sort of taken, and she was not given any credit for that. And there's a whole book on that. The syphilis study at Tuskegee. So many of you know that there were experiments experiments that were done, or basically Black men who had syphilis were not treated with antibiotics when antibiotics became available. And this study went on and was basically done by the U.S. Public Health Service. And was continued from 1932 to 1972, where they didn't explain the risks of syphilis or allow treatment for syphilis in these Black men who were at Tuskegee. And then there have been many incarcerated Black men who underwent experimentation with toxins and exposures to viruses where they weren't really given the full benefit of informed consent. So we have this history in the US and need to realize that as we really try to increase diversity in clinical trials. So, diversity in clinical trials is important. The NIH has a website that discusses the importance of diversity in clinical trials. We know that if we want to to decrease inequities, that it's really important that we have lots of populations that represent the populations in the U.S. To be involved in clinical trials. And to that end, the FDA devised a draft guidance where they discuss enrollment of participants from underrepresented racial and ethnic populations in clinical trials. So this guidance was started in 2022, and it doesn't have the rule of law to back it up, but it's there and you can find it, and it really does talk about trying to increase diversity in clinical trials. And then there's a report by the National Academies where they prepared a consensus study that reviewed the necessary steps for increasing representation in clinical trials. And they go through what are those sort of aspects of trying to increase diversity, why it's important, why it's necessary. So with this, the thought of really increasing diversity in research, we started the Justice, Equity, Diversity, and Inclusion Center for Transformational Research, so the JEDI Center. And this is through the Office of Healthcare Equity. And our mission is to improve the health of the public and eliminate health disparities. And the vision for this research center is to study and ultimately eliminate health disparities by promoting the principles of justice, equity, diversity, and inclusion in the research of our marginalized and minoritized populations, and to really increase recruitment, retention, and advancement of students, residents, fellows, and faculty from groups underrepresented in medicine, and to also collaborate and partner with our community to increase diversity in our research efforts. And so with improving the health of the public at the center of these efforts, we want to utilize community engagement to improve the health of the public and eliminate health disparities and inequities. We want to use the arm of clinical care. We want to actually use collaborative research and then make sure that we have an activated and educated workforce. So these are some of the pillars of the UW Jedi Center. And I'm going through this because this becomes very focal in our diversity and clinical trial efforts. So some of the objectives of the UW Jedi Center are really to be a foundation to of health inequities research that includes evaluation of some of the intersections between our social determinants of health, where we live, work, play, and our biologic and environmental forces, as well as justice and access to health care. We also want to disrupt health inequities by supporting the ecosystem, and ecosystem used to be our pipelines of potential researchers, so that they have the tools to conduct basic translational, clinical research to transform our healthcare system and really sort of close the gap of the health disparities. Diversity in the workforce really increases our ability to interact with and provide care to our historically minoritized communities, and contributes to trying to increase excellent in patient care and community building. And we want to collaborate with our affected communities and to develop a research agenda so that we can really start to decrease these health inequities and also lead to improved community relationships. So these are sort of the objectives of the UW Jedi Center, and I tell you this so that as we go through the new legislature, much of the work will be done in this center here. And this is a center that was funded from a generous donation from the Chow Foundation, and it is funded to basically do this work. So I'm going to move on to diversity in clinical trials. So this is new legislature that was developed last year in the Washington State Legislature. It is House Bill 1745. And this was brought about because community and University of Washington wanted to increase diversity in clinical trials. So this was really a community-driven effort. And I'm just going to share with you direct information from the bill, and it's something that the university will be doing, and it will affect a lot of our clinical research, and we're still in the process of determining how this will be rolled out at the University of Washington. So basically, the UW in this legislation states that diversity in clinical trials is necessary to effectively determine how race, gender, and age impact how a person metabolizes a drug or has interacts with some new device. And the lack of diversity in clinical trials also compounds access to treatment. Disparities and limits our understanding of the impacts of studied interventions and conditions across the population. And so they defined underrepresented community or underrepresented demographic groups as communities or groups that are more likely to be historically marginalized. And so this includes race, ethnicity, gender, sex, sexual orientation, socioeconomic status, age, and geographic location. And I would also add ability here. So they define this in the legislation, um, and basically come up with points that we need to do as an institution to increase diversity in clinical trials. So, so from section 1 of this legislation, we have to improve the completeness and quality of data. So we need to know who's actually getting recruited into clinical trials. We need to sort of transparently show what the data that is collected, reported, and analyzed for these clinical trials for drugs and medical devices. Uh, the the legislation says that we have to also identify barriers to participation in clinical trials by members of underrepresented groups. We also have to make data concerning demographic groups that is collected, reported, and analyzed more available and transparent. And we also have to offer trial participants information in a language other than English and provide culturally specific recruitment materials alongside the general enrollment materials. So we basically have to make the data transparent. We have to identify barriers, and I'll just talk a little bit about that. And we have to make data concerning demographic groups more transparent. So the Washington State Department of Health actually did a study where they identified barriers to participation in clinical trials and published those data. They also looked at what were the demographics of participants in a lot of the clinical trials that are done in Washington State. And as you can imagine, the number of the percentage of participants is the majority are white participants. So we're expected to increase the diversity and to provide language and translation services. So this is the specific section that is very specific to the University of Washington. So if the University of Washington receives funding from the NIH to conduct clinical trials or drugs or medical devices, we have to adopt a policy concerning the identification and recruitment of persons who are members of underrepresented demographic groups who are going to participate in these trials. And that policy includes the identification and recruitment of people to these trials. We also have a requirement that we are going to be conducting clinical trials in collaboration with community-based organizations, which is very new and something that you know, the NIH and FDA has always said that we need to do, but haven't really provided a way to do that. We have to, again, provide information to trial participants in languages other than English, and they don't specify, is it, you know, the top 10 languages, or what languages you have to do that in, but we have to, as researchers, provide information to trial participants in other languages. We also have to provide translational services or a bilingual staff for trial screening, and then to provide culturally specific recruitment materials, and provide an electronic consent. So this bill does provide monies for translation, and we're involving the translation services at Harborview to help us with trying to figure out what that will look like. And I know that there are trials I heard about Blossom where, you know, researchers, you all are already doing this. So now there will be some funding to actually do this. And there is right now, there's a development of policies for that. So I'm going to talk a little bit about the policies. So Jason Malone, who heads up the Human Subjects Division, has been a part of our sort of steering committee where we've been discussing this, and we've been meeting on a regular basis to try to determine what should we be doing at the University of Washington to really increase diversity in clinical trials. And it's his office that is charged with really determining what policies and procedures related to research we need to have. So he's in the process of developing that. So UW Executive Order 24, which has to do with research with human participants, basically says that the UW has the administrative and oversight structure, and that's in the Office of Research, through the Vice Provost of Research, to facilitate and ensure excellence in research. And so all the policies and procedures related to human research are developed through his office and currently under Jason Malone. And so in this, in the current legislation, what his office will do will develop a set of institutional policies that will provide guidance for researchers. So identification and recruitment of underrepresented groups, collaboration with community-based organizations, which our office is going to be leading, the use of methods recognized by the FDA to identify and recruit populations, culturally specific recruitment materials, so we're working on that, and the use of translated materials with limited English proficiency study participants. So, and then provisions of interpretive services, and then provisions of an electronic consent if that is applicable. So again, our office is working on the collaboration with the community-based organizations. So this is a fundamental change, and what was once an opt-in approach will now become something that's required, and what that means is something that we're working on right now. And the goals are that the Human Subjects Division office will provide researchers a framework of expectations to accompany this new legislation, and that we're going to work with all of our researchers and our community partners to make sure that we have adequate resources for researchers to comply with these new requirements. So this is from his office. So this is going to be done in phases, January through July 2024. We've been going through phase 1, where we're looking at the scope and applicability of this legislation to UW research. We're trying to get baseline metrics from our clinical trials measurement system and EPIC. So we're going to align those to see what the demographics of our clinical trials are. We're also planning to collect social determinants of health and develop metrics. There's going to be sort of pre-award and post-award resource allocation pathways, and then this phased-in implementation. So this is what that will look like. We have now a strategic leadership committee, and I'm leading that committee with folks from ITHS, so many of our clinical researchers, and Shelley Sakayama Elbert, who's the Vice Dean for Research and Graduate, our Vice Dean for RGE. And so we'll have these different parts of this sort of evaluation. So human subjects, there's going to be a data and collection and reporting arm, the community engagement arm, resource allocation, and communication and training. There's going to be a baseline of an ongoing data collection. So data from the clinical trials management system will be connected with Epic so that we can get race, ethnicity, sex at birth, which are immediately available, and then hopefully to get things like social determinants of health in the future. And, you know, I'm not sure how this will be done, but the impacts of biosets in the future. And we've there's there's already been some work with this clinical trials management system. So this is a system where all the clinical trials go into. They have their own database called Encore. They've been linking that with Epic. And so what they've been doing is really trying to get an idea of what our clinical trials look like. And so this is just an example of some of the data that they were able to pull. And the current analysis suggests that the clinical trial participants represent about 3.4% of the UW medicine patient population. And the majority of our participants, again, are white, and fewer are American Indian or Native Alaskan or Asian or Black or African American compared to who are enrolled in clinical trials compared to our UW medicine patients. So gives us an idea of what that will look like. And then resource allocation and pathways. So our community engagement, we are really working on trying to develop what this is going to look like, and how we're going to do this. So we have this advisory committee that will also include our community partners. And so really thinking about this community engagement has been something that our office has been involved with. And so we have been reaching out to the community to help us with this. So we started meeting with community-based organizations probably around September, maybe just a few months after this legislation came out. We're using the AAMC toolkit to further engage communities, and we've been meeting on a at least a either monthly or every 2-week basis. What this legislation did fund was some FTE for faculty, FTE for a community engagement person who's probably going to be located in our office, and money for translation, but did not have any funding initially for CBOs. And there's supposed to be funding for community-based organizations so that they can actually do this work, because that is something that we, if you do community-based research, community-based participatory research, that the communities need to be funded to do this work. It can't be something that's voluntary. So to that end, we wrote a grant that we submitted to the American Heart Association through their HERN mechanism. We just submitted that grant, so we'll hopefully get some information about that by June or July, so that we could partner with our community-based organizations. And some of the aims of that grant are to do listening sessions to further our community engagement and to really develop a community-based research collaboratory, or CBRC is what we're calling it. I mean, that's what we called it in the grant. And so this will help us to engage our researchers, to engage our policymakers, and engage our community so that we can start to really think about how we're going to do this mandated process that the Washington State Legislature says that we must do. Our community engagement will include memorandums of understanding. We need to think about how we're going to integrate funding for our community-based organizations and our researchers to do this work. We want to add a community-based organization member to our diversity and clinical trial steering committee, and then consider other community engagement sort of research and clinical and educational priorities. To evaluate what we're doing, that is what we proposed in the grant, that we'll use something called PRISM as an implementation community engagement way to measure what we're doing. And this is sort of a equity-based implementation framework that uses the REAIM outcomes, and REAIM is something that is used for implementation that includes reach, effectiveness, adoption, implementation, and maintenance. And so our timeline is that we're going to do phase 1, which is the scope of this sort of human subjects policy development, where phase 2 is implementation and resourcing of the policy. Phase 3 is our applications to the human subjects policy, so that to make sure that they align with the legislation. And then the funded studies to start to actually be to go down this pathway. So it's all going to be phased in. We're not going to ask people who've been funded to actually sort of align with this just yet, but to do it for those who probably are going to be applying for research funding in the future. And I wanted to, before I end, I just wanted to talk a little bit about the Kidney Precision Medicine Project, KPMP, because KPMP has been involving community in basically everything that they do. And we reported on return of genetic results because that is something that I've been involved with. But many of you are involved with KPMP and know the goals of KPMP, which is basically to obtain kidney biopsies, further define disease subgroups, and then identify critical cells, pathways, and targets, and then create this kidney atlas. But what's been a big part of KPMP has been the community engagement. And Kathy Tuttle led this with a community engagement co-lead from the community, where there is a community engagement person who's involved in all the aspects of KPMP. The patients and or the patient participants are in all the meetings and calls. There's steering committee representation. The first draft of the informed consent was really done with community engagement and patient participants and community participants involved in that. And then the policies have all been done with community engagement. And phase one sort of started back in 2017. Now there's this funded whole genome sequencing, which I've been more involved with. And we know that I think enrollment now is up to, I think, 350 biopsies. So their enrollment has continued. And the return of results for genetic return of results is something that we've been involving patients, community members, ethicists, clinicians to develop a return of results pathway. And much of this work was done with community engagement and really allowed for development of workflows that accounted for participant autonomy. It accounted for CLIA and New York State rules, and will have the KPMP participants having to get another confirmatory blood draw for this. And so the return of results, some of the key decisions were that we wanted to prioritize patient autonomy and the balance with clinical comfort in getting ACMG results. What came out of the community engagement is that we thought that APOL1 needed to be treated differently, as did sickle cell disease, because these were potential genetic findings that would really alter, you know, needed to really be run by the patient participant before it was shared with their medical team. So APOL1 and sickle cell disease results will be shared first with the participants, and then the participant will have the choice to either share it with their medical team or not. So that was one of the outcomes of this community engagement for this result. And this is the workflow that developed, and I won't go through that, but just wanted to show that this was really influenced by community engagement, and again allows for the patient participant to have the choice of whether or not they want certain results shared with their medical team, and those results will go into their medical chart based on what the patient participant wants to do. So we've already gone through seeking community engagement here, the steering committee and DSMB approval. I think the IRB approval has already been done or is in process, and once this process starts, they'll have consent of the participants with the return of results consent. So these are some of the steps that we went through. So for KPMP, the participants will undergo whole genome sequencing. The APOL1 and sickle cell disease will be given to the KPMP participants first. And genetic counseling will be offered to all the participants if they need it. and participants will be given the choice of sharing positive APOL1 or sickle cell disease results with their medical team. So in my last minute, I think my conclusions are that racial and ethnic health inequities exist in medicine and clinical trial enrollment. Community engagement is something that we need to do at the beginning of research to really increase and it will help us to increase our outreach to historically marginalized and minoritized communities. This new law, HSB 1745, is basically forcing us and other state institutions that receive NIH or industry funding to increase diversity in clinical trials. And we have to partner with communities, make data concerning demographic groups collected, reported, and analyzed more transparent, offer participants information in languages other than English, and it's requiring an electronic consent when possible. So just want to say thank you to all the folks who have supported me. Thank you to the folks in the clinical trials office, and I'll end there.
Thank you so much, Bessie, for bringing this talk to us. And I mean, been said before, but of course, thank you for doing this really important work. I suspect the research group may, want to have you back for more discussion.
Okay. Yeah.
Looks like we're a little short on time, so time for just one question. And looks like Susan's going to snap up that opportunity. Go ahead, Susan.
Thanks. Thank you, Bessie. This is really compelling stuff. And I agree. I think some of these measures are going to really help to improve participation. I wonder whether or not in your steering committees, there may be representation in investigators who do behavioral interventions, because I think the impact of these policies may impact upstream onto the intervention itself. So I'm just speaking from a palliative care perspective. We're testing communication frameworks and language that was developed in English-speaking populations,
Right.
and that while we can, convert the consent, translate the consent forms, the intervention itself can't be directly translated, or if it is, it could even be potentially offensive in the worst case scenarios, or just not land in the way that we think. And there's so much deeper work that needs to be done to make culturally and language specific kind of frameworks. I could see the same thing with in psychiatry or certain therapies. And so just wonder with the unintended, potentially positive in terms of it'll really force people to start developing other more culturally appropriate type of behavioral interventions, but then also the unforeseen negative impacts that people may rush to just try and translate something and then it land in an offensive way. What's your thoughts on that?
Yeah, so that's a great question. And I'll just say that there is a lot of room for research. This is sort of rolling out. I think that those are excellent questions. We'd love to have you participate if you want to be on the steering committee, but I know you're busy, or if there are other folks who want to be on the steering committee. I think there is a lot of room for that kind of research to be done, because right now we're just trying to figure out what we have to do to be compliant with this law. So, which means that there is the potential for a lot of research as it gets rolled out and needs to actually start now. So, Ian, so I know I didn't answer it completely, but I know that we're short on time. So, and then I can answer in the chat, Ian, your question about what resources are going to be involved with that. So.
Thank you again. Thanks so much, Bessie.